now
Okay.
we would like to move on to the second invited talk, which is Eran Tal from McGill University, who will talk about target specification bias, counterfactual prediction, and algorithmic fairness in healthcare. Will you please try to share your slides? Yes. That looks great. Thank you. You can start when you're ready.
Hi. Thanks very much for having me here, and especially to Andy King for inviting me to this wonderful symposium. So as Asa kindly said, the title of this talk is Target Specification Bias, Counterfactual Prediction, and Algorithmic Fairness in Healthcare. And the question I want to start with is, are labels reflecting the target variable? This is a common question when you're training a supervised machine learning model for healthcare decision support. Are the labels in my training data, do they reflect the variable that decision makers are interested in predicting? And what I want to urge today is the idea that even when your data set is representative and well curated, there's still a reason to suspect that the labels do not reflect the target variables that decision makers are in fact interested in predicting. And here's why. In an actual scenario, what your model is trained on, in the best case, is something like this. The health outcomes in the training data set are causally are caused by the patient features as well as the features of the intervention, the healthcare that these patients receive. But the question is are these health outcomes the ones that you want to predict? To give you a kind of a famous example from Rich Caruana, he recounts this in 2015, but the actual example comes from the early days of machine learning in the mid-90s. Caruana and his team were trying to predict the survival rate of pneumonia patients. And their model turned out to be to predict that patients with asthma have a lower risk, a lower health risk than the general population, which was a strange result. And how did this happen? Well, asthmatics, when seen by hospital staff, were and presenting pneumonia symptoms, were rushed into intensive care and treated aggressively. And so their survival rate on average was higher than that of the general patient population in the Pittsburgh area hospitals where the data came from. Now notice that the data itself is perfectly fine. Collecting more data or having more representative data will not change this pattern. This pattern is real, but it's not the pattern that you want as a physician to be using in order to allocate hospital beds, right? What you want to predict is not the actual scenario in which there is there's the downward arrow. Patient features have a causal effect on the intervention, right? Being an asthmatic intervenes on the kind of effects, the kind of intervention you will get. But what a doctor wants when they allocate hospital beds is a kind of idealized scenario where patient features do not interact with the intervention they get, with the treatment they get. For a decision maker, this interaction between patient features and features of intervention is a confounder. And once you remove it, once you get the expected result that this asthmatic is in fact a higher suffers from a higher risk of complications or death, and using the actual scenario, the actual labels to calculate your accuracy would get you would put asthmatics at risk. And this is of course a fairness problem, because asthmatics will be discriminated against in this process. And this is what I call target specification bias. It's unfortunately still not a very researched and investigated bias within medical AI. And I define it as a misalignment between the definition of the target variable by decision makers and the way algorithm designers operationalize the target variable. If you don't correct it, then for some patient groups, the predictive accuracy reported to decision makers is going to be overestimated. And this happens even when labels are reliable based on gold standards and representative and predictions match labels. In fact, the very problem is that that when predictions match labels, it's very tempting to say that the model is accurate. But matching labels doesn't mean that your model is accurate from the perspective of decision makers, from the perspective of say, physicians who, or hospital administrators who need to allocate resources. So target specification bias diminishes both accuracy and fairness. What is the root problem here that's been making this bias persist while other types of biases have been addressed in the literature, as we saw in just the previous talk? I think this is the main reason. And I call it the label matching conception of accuracy. It's very, very common among reports of accuracy as one of the key measures of performance of machine learning models to think of accuracy as a type of label matching. Now, there are lots of measures of accuracy, of course. You can talk about log loss or confusion matrix or area under the curve or the F-score. And if you're doing regression, you can talk about root mean squared error or R squared. But all of these, in the end, are different ways of calculating a match between predictions and labels. They all give you 100% when labels match, when predictions match labels at 100%. But remember the asthmatics in Pittsburgh. If you predict that for them, they're going to be at risk. So for treatment selection, for diagnosis and resource allocation, for all these decisions that involve some kind of intervention, you need to treat some of the causal mechanisms that gave rise to your data as confounders and correct for those confounders. These are all these standard metrics of accuracy end up being biased, not because your data itself is bad in any way, but because it reflects downstream effects of clinical decisions. So what's the solution? I think part of it is simply a conceptual shift in the way we think about accuracy. And here I go to a completely different field that some of you may have heard of, but it's not a very famous field, the field of metrology. Metrology is the science of measurement. And metrologists have been thinking about accuracy for many centuries now, because they are the people who work at standardization bureaus. They standardize things like the standard kilogram, the standard meter, the standard second. So they've had a long time to develop methods to evaluate and improve accuracy. And according to metrologists today, accuracy is the closeness between the measured quantity value and the value of the measurand, the target variable, as it is defined. And the word defined is really important here, because metrologists distinguish between the definition of the measurand, the definition of the variable to be measured, and its realization. And metrological realization is some approximation of the definition of the measurand, some concrete way of approximating it. Here's an example. Let's say that you have a clock at your home, like the clock at the bottom here. Usually there would be a quartz crystal oscillator in there, and a current driver being driven through it, and it oscillates, and that's how you get the time. Let's say you want to know how accurate your alarm clock is, but you want to know it really well. You want to compare the frequency of your oscillator, your alarm clock, to that of the most accurate clock in the US, NIST F1, one of two most accurate clocks in the US, and also one of the primary realizations of the SI second. This big machine is housed in Colorado, in Boulder, in Colorado. and in it are cesium atoms. And because the definition of the second is based on the frequency associated with the transition between two energy levels of cesium atoms, when you compare your clock to that big fancy clock, you can tell how accurate your clock is. Well, are you done? If you ask metrologists, well, here I showed you that my clock and your clock have the same frequency. Can I say my clock is accurate? We'd say, well, not so fast. There's an additional uncertainty, and this is the second arrow up top, because our clock in our lab also has some uncertainty associated with the definition of the second. The definition of the second is idealized. The cesium atoms are supposed to just float unperturbed, devoid of any magnetic fields or temperature oscillations. But the actual clock in our basement in Colorado deviates from the ideal. So there's additional uncertainty that have to do with the difference between the ideal counterfactual definition of the second and the actual way, and way we realize it. You can already see the analogy with the asthma case, because what I care about when I calibrate my clock is not how well it reproduces some other instrument, but whether how well it fits the counterfactual definition of what I'm trying to measure. In this case, the definition of the second. Going back to supervised machine learning in healthcare, how do we apply this conception of metrological accuracy to this area? Well, one important thing is to distinguish among three levels of biases, or three different kinds of errors in machine learning. If we start with some event in the world, such as the detection of a pathology, the first type of error, and many different kinds of biases go into this error, but this family of biases can be called data acquisition errors. Those are errors that have to do with a problem in capturing the world with your actual labels. For example, missing data or unrepresentative data would go into this category. But having your actual labels is just the first step. Your actual label is a record of some pathology detection, but what you want is, of course, not to predict the records. You want to predict the existence of pathology. That's the intended label, and that's where the umbrella of label bias comes in. This is where you have to correct for all sorts of problems that arose during the data generation process itself, such as diagnostic errors, for example. But the important message from my talk is that you're not done simply by predicting your intended labels. You have to also account for target specification bias. And that's the distinction between your intended label and the target variable. The target variable in most cases of decision making is a counterfactual state of affairs. For example, the existence of a pathology in the absence of confounders. That's what you actually want to tell your decision makers. Going back to Sarah's talk, that's what you want to include on the label of your prediction device as your performance metric, not the level of the degree of match between predictions and intended labels, but the match between your predictions and the counterfactual existence of some pathology or risk in the absence of some confounders. Well, how do you do that? How do you evaluate target specification bias? I think that there's still a long way until we come to complete grips with this type of bias, but there is already some work that I think is very important that's being done to tackle it. A big part has to do with counterfactual modeling of data, and especially causal modeling of data through methods like target trials and transportability. These methods use Bayesian causal modeling, counterfactual modeling, to find counterfactual dependencies among variables. But notice that to do that, you can't just have a general neat formula that you standardly apply to everything. You have to know a lot about where your data came from and the specific procedures and processes. For example, in Pittsburgh area hospitals, you have to have a lot of domain-specific knowledge. You have to speak with the clinicians, with the administrators to help you understand the causal structure of your data. You have to do all that in order to evaluate accuracy in a responsible way. And finally, you have to report those numbers. It's still okay to report area under the curve as a kind of an internal validity measure. But what your decision makers are going to care about is not the area under the curve for some label matching measure. It's the counterfactual accuracy of the metrics, and that's why I think we have to start thinking about accuracy in machine learning in healthcare along metrological lines. And here's a QR code to the full paper. I very much appreciate any feedback, including by emailing me if I don't manage to reply today. Thank you very much.
Thank you. Yes, that was great. I feel like we have some questions from the panel, but also a reminder that there are Q&A questions for everyone else that you can submit your questions. But one directly from me. So I really like this framework conceptually, that we're missing some confounder, and it's pretty clear in the asthmatic case that we are. However, if what we're actually trying to predict in the asthma case, or in this acute respiratory failure case, is amortized risk of mortality, for example, are they going to die, right? How do we, if that's the intended label, how do we get clear measurement of that risk, right? That's a very conceptual, amorphous type of thing, and it's always going to be confounded by a decision, right? Deciding not to treat is also a decision. So there's no confounder-free observation.
Yes, that's correct. And what I'm proposing is that you get clearer on exactly how you define the risk, and then ask yourself, how did I operationalize the risk? And then realize, okay, there's a difference between how I define and operationalize. Now let's do some counterfactual analysis to tell the difference. So there are three steps here. The first step, defining risk of mortality. What do you mean by risk of mortality? Do you want to predict how many people with certain conditions will die at these hospitals? That's very different than asking how many people with this condition would die at those hospitals unless they're being treated in some way, right? Or the counterfactual question, how many people would die if we treated everyone equally, right? That's, again, a very different question, because, of course, in hospitals, you don't treat everyone equally. You treat them based on their history and symptoms. So, first of all, that definition matters. Then the operationalization, then you have to ask, okay, in the data that I actually have from these hospitals, what are the causal connections? How is this data generated? What are the underlying processes that give rise to the data? And then the third question has to do with the difference between the definition and operationalization. So in the case of metrology, life is easier because we have general theories of how cesium atoms would be like in the absence of, say, magnetic fields. We can calculate that. We can idealize using theoretical models and predict what reality would be like under counterfactual conditions. In medical cases, it's just much harder, right. And that's why you need to be very familiar with the processes underlying your data. Okay.
Yeah, I think that validation problem will require some domain knowledge. So at this point, we're going to take a short break. So thank you again to Eran Tal. will return at 3:35 GMT, so 5 minutes